Over the past 5 years, I've probably interviewed Geert Vanden Bossche the most, at least twice a year. And I've kept all of those interviews, and I've had the luxury of discussing with him before and after presentations to really get an insight into what he's thinking. I certainly don't ignore what he says. Now, there's a proviso in that it's very difficult sometimes to grasp a lot of the science that he speaks about because it is so complex. And sometimes when you try and give timelines, it can be extremely difficult. And many people sometimes will discount what he said because it hasn't quite fit to those timelines. But what I've learned over the years is that what he says will eventually become clear. When at the start in March of 2021, he spoke about the mass vaccination risk and the evolution or the continuous evolution of viral variants, it was discounted. But very few in the scientific community who remain objective will decry the fact that he was correct, that we have now got the most frightening speed and development of variants we have ever seen. It's not stopping. Now, people may try and discount these variants as being mild, but as I warn people, once this virus breaks through mucosal immunity and gets into the bloodstream, it does all kinds of damage. I'll show a paper that has recently been published, just actually yesterday, I think, where it was showing the increased risk of stroke, heart attack, within about a month of a COVID infection. They're also seeing it with influenza. But the important point is that COVID usually opens the door for more other viral infections. This is where it works in opposite to many other viral infections. When you get an infection, say with influenza, you'll have a strong interferon response, and therefore it's difficult for another virus to come in on the scene unless you're immune suppressed. With COVID, it's different because it suppresses interferon and it damages the immune response. And so, therefore, the risk of other infections increases. So, you'll have multiple infections at the same time. But let's get to what Geert has been saying just recently. And this is from Geert's Voice for Science and Solidarity. It's in the description below on the 30th of October. And I'll try and explain some of the points he's making here. He spoke about suboptimal population level antibody responses. And what effectively he means there, it's not the level of antibody response that is so relevant here. It's the fact that when you look at the antibody responses, they are not able to effectively neutralize the virus. They're the wrong antibodies. It's not what you need to neutralize them. And what is not properly acknowledged is the fact that for many people, or what the evidence is showing us, is that the primary antibody being produced is still to the original variant by times of difference, meaning that if it's 400 for the new variant, it will be almost 16,000 for the old variant. That's a problem. It suggests the immune system is locked. So that means antibodies are not effective. And that's part of the reason why COVID continues to circulate, especially in highly vaccinated regions. So as we go along with what he said, that it makes the SARS-CoV-2 progressively less infectious in highly COVID-19 vaccinated populations, whereas suboptimal population level T cell responses are now making it less virulent, meaning in terms of the severity of the infection, thereby explaining the overall shift from acute to chronic infections. The important thing here is that, as I have said on many occasions, if you look at the mildness of the infection to determine the severity of it, meaning that whether or not it's a relevant infection, that is the wrong way to look at this virus. In the same way, you shouldn't look at the fact that HIV, when someone gets infected initially, within the first 4 weeks, they have only a very mild viral infection, but it goes on to cause severe long-term damage to the immune system. So don't get caught up in just the initial presentation. It's far more complex than that, and therefore why we have to be careful. Let's continue here. While suboptimal antibody responses exert collective immune pressure on viral infectiousness, suboptimal T cell responses exert collective immune pressure on viral virulence. Now, what he has been saying about T cell responses, and I've got a few slides to try and help people to understand what he was meaning when he spoke about these T cell responses and where they were targeting. You have to understand just how the virus works, or not how it works, but what the setup is in terms of the virus. So what you have here is an image of the coronavirus structure. In blue, spike proteins on the surface. And then you can see this gray circle is the envelope, or the wall holding everything together. It have envelope proteins, membrane proteins, and then on the inside you have nucleocapsid proteins. The mistake, in my view, with the pandemic is that they focused all of their attention just on the spike protein, which is also the part of the virus that changes the most. But what Geert is talking about is that the T cell responses very often include the nucleocapsid proteins. And it's just about the way how the immune system works. As I say, antibodies are like the bullets. The T cells are like the Marines. They don't just shoot at the virus, they blow up the building. So the T cells will target virally infected cells. And when it comes to the T helper cells, and this was very important when Geert highlighted it recently, they coordinate the battlefield. And so if they are being evaded, not even the antibodies will be effective at controlling what is happening. And so that's a big part of the problem, is that he is predicting, and he had evidence to show it, that the nucleocapsid is changing because of the immune pressure. And what that means is that when it changes enough, not even the T cells will recognize the virus when there's an infection. And so what you have is a silent infection. That's similar to what happened with interferon responses, where even though people were infected, they didn't have any symptoms. It didn't mean that they weren't going to get severe symptoms down the line. Continuing along with what he said, we have witnessed with our own eyes how increasing immune pressure on viral infectiousness drove the selection of progressively more antibody evasive variants. That's like Omicron. And as he said, it abruptly gave rise to the highly infectious Omicron. Yet it remains a mystery to me why hardly anyone seems to realize that increasing immune pressure on viral virulence is now driving the selection of increasingly T-cell evasive variants on evolutionary process. And that will inevitably culminate in the sudden emergence of a highly virulent Omicron, highly virulent Omicron variant. That's what he calls the Omicron. And he strongly believes that this is an inevitability. It's not a matter of if, but it's a matter of when. And when you look at what the reason he says that, and I had saved this from his from the last presentation, is that he was highlighting that when you looked at the speed of the change of variants, this was where it was earlier in the year, up into late 2024. This was September 2024. Then by the January 2025, you can see the angle of change is starting to get steeper and steeper. And so there will come a point where it will evolve not only over, this here was about from the 10th over 10th to the not the 10th, this was from May to August, 3 months. It will then become 2 months, then 1 month, then weeks. And as that evolution occurs, the immune systems are unable to cope with all of these infections. And this is where Geert is predicting things will be. My question, as always, was to do with what is the clinical presentation? So, even though you may have a very virulent virus, because of the way how the immune system responds and the body responds, you can see very different and abnormal patterns clinically. And for me, based on what he is saying, is that if you have a variant that is able to infect and continue to replicate unchecked without any strong immune response because of IgG4, which is immune tolerant, you have poor antibody targeting, T cells are not responsive, then you have a situation where the virus just continues to replicate. The question is, how does it present? How do people die? I'm going to have to give you this in a story format. And it's something that I saw, but I'm trying to put it in a way that there can be no clear link to where and how. But this is the principle. And I saw this with my own eyes, so I recognize how this can occur. This was a patient who did have COVID, probably about a week after. They were recovering, they were fine. They were just waiting and preparing to be able to go home. This is in hospital. And a few years ago, so I remember it very clearly. And I remember seeing the person just getting their breakfast, and they were struggling to coordinate with their hands. They were spilling their bowl of porridge. And I knew something wasn't right. I thought possibly this was a stroke or something. And what then happens is you try and see if you can get imaging done to try and see if you can understand what's going on. And within about, I'm trying to remember the time now, about 9:20, within about 40 minutes, I was then informed that the person was not just initially a little bit confused and unable to coordinate their limbs, they were then comatose within 40 minutes. I hadn't seen that before. And then within another 30 or 40 minutes, that person then passed away. It was absolutely rapid. I hadn't seen it before, and I hadn't forgotten it. And what I came to the conclusion of was that this had to have been brain stem failure, because the incoordination when they were trying to use their spoon and the bowl, spilling it, they just couldn't control where their hands were going. That fits with what can happen in terms of damage to the brainstem, say with a stroke, which is why you would think that. But for the brainstem to completely fail, where they are unable to be awake, and that's where you get comatose, brainstem failure. People oftentimes don't respond so much. And then in order to stop breathing, that again represents brainstem failure. And so my conclusion, looking at it, just observing it, was that this was a very acute brainstem failure. Now, it occurred about 5 days after infection. And coincidentally, I had seen a similar pattern just days later with someone else. And so I knew there was something here. So this is now me giving you the picture as to what and how I think this will present. And remember, this is just my opinion. This is not research. This is anecdotal observations tied with me thinking about the science and what the implications could be. So I'm just going to show you what I had thought in terms of end-stage viral disease. So in this case, what you would then be seeing are people who have an infection, just replicating virus. They initially don't have any symptoms, and then suddenly they get unwell. Kind of like what we would see in patients who are on, say, chemotherapy and are septic. Very often they look absolutely fine and then suddenly get unwell, crashing their blood pressure. That's the kind of picture that you can see. And in this part of my Omicron presentation, I was looking at end-stage viral sepsis, the immune exhaustion, and this was what I thought would be at the end. The early phases, what we've been through for the past few years, moving into metabolic collapse, where people are now having organ failure, and then you have the end stage viral sepsis. It's important to note when I predict that this is not a linear thing, meaning that what you will find is some people initially, primarily in the early phases, not very few in the later phases. Let me just show you what I mean. 2 or 3 years ago, the majority of people, in my estimation, would have been in these three categories: smoldering inflammation, immune dysregulation, persistent infection. But as the years go by and you have more and more recurring infection, a percentage will then overflow into metabolic collapse. This is where they're having no organ failure, heart failure, kidney failure, their lungs aren't working so well. And then as more and more people fall into this category, you will then start to see some falling into the end stage viral sepsis. And this is where I suspect that it will catch people's attention, because this phase, many people are just older with comorbidities. You don't really worry about it too much because it can happen. But this stage would be unusual, and it would therefore possibly catch the attention of the scientific community because it's sudden. And this is a very important point, is that the reason why COVID got so much attention was because people got sick so quickly. In reality, we are still having more deaths than we did in 2020. I mean, broadly across the population, but it's not sudden. And so therefore nobody's bothered. That's the problem, is that it's only when it happens very quickly and dramatically that everybody suddenly sits up and goes, oh my goodness, we have a crisis. The crisis was always there. It's just that it wasn't obvious if you didn't know what to look for. And so here is my prediction, and this was from my presentation about a few months ago, is that they will have multi-organ dysfunction, kidney failure, heart failure, lung failure, confusion. Their D dimers will be elevated. Then they will almost die from exhaustion. And this stage will come on very, very quickly. They tend to be the frailer patients, maybe patients who are very immune suppressed, and some portions of people who just appear burnt out. They just look sick. And at that point, you can't miss the fact that they're sick because they're confused. They, at some points, have unstable vital signs. Towards the end, they become and start looking septic. But when it presents, it is very, very quick. And that's where I think it will catch people's attention. But in reality, I don't think this is new. It's just that we have what could be a perfect storm of things coming together. Every time I talk about a storm, please, if you haven't been paying attention with Melissa hitting Jamaica, this was like the perfect hurricane. Category 5 did huge devastation. Please remember them in your prayers and support them whenever you can. In the same way, with the hurricane analogy, when it hits, it can be devastating. No matter how much you prepare, you can't really keep up with the changes when they happen. And that's my concern, because if we are not prepared, if people continue not listening to Geert, ignoring what he's saying, not having contingencies, whether or not you think he's right, it's at least reasonable to consider the possibility. The final point I will say, I am working through some very important documents, looking at about 8 years of data, huge data files, looking at admission diagnoses and so on, and looking for patterns to try and explain how disease will present. So over the next few months, I'll be picking out simple bits to try and explain them. One of the most stunning bits that has come out so far is that a significant reduction in sepsis cases are occurring in hospital. Now, I know that's not possible. What it means is that they're not being picked up. People are already presenting in an unusual fashion that is not being recognized as sepsis, because there would be no logical reason for deaths to remain high. And we see an almost, I think it was an almost 50% reduction in numbers. Unbelievable. Doesn't make any sense. So I'll be unpicking that kind of data soon. But just to highlight the point that patients are presenting differently already. When a very evasive variant comes along, that's the example of the perfect storm. Remember, like, subscribe, share, make a simple comment, even if it's just thank you, and look in the description below for the link to Geert and other important things, especially about humming heroes, to make sure that you've got a health plan in the next few months as we continue to prepare. Hope for the best, prepare for the worst. Have a great evening.